Welcome, 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 everyone. Thank you so much for being with us. This is the second of our community conversation series that the Racial Equity Task Force has committed to holding. We have Dr. Tara Mold, who is a generalist OBGYN at Brigham and Women's Hospital. We have Corinne Prescott. She is a social activist, advocate, and organizer. Attorney Nichelle Mullins, who has served as the president and CEO of Charter Oak Health Center, Inc. since 2015. We also have Dr. Camelia Lawrence. She is a board certified surgeon specialized in malignant breast disease. And last, certainly not least, we have our moderator that we are so excited to have with us again, Miss Mercy Adekola.
Hello. As I said before, I'm Mercy Adekola, and we have all our panelists here. You guys are the representation that we need in our Farmington community for strong, powerful Black women, and I'm super excited as well for this conversation. My first question to you guys that I guess that I'll address to Dr. Lawrence, but anybody else can jump in and add in after. So what are some of the biggest threats to health equity that you are seeing amongst your patients and in the healthcare industry in general?
As it pertains to breast cancer among women of color, we have a higher mortality when compared to our white counterparts. So women of color are almost twice as likely to die of their breast cancer diagnosis. And there are a multitude of factors, include late-stage diagnosis. A part of it has to do with the biology of the tumor as well, and also access to treatment and access to culturally competent quality care for the diagnosed cancer.
One of the things that prohibit poor Black folk like me from getting better or having access to better healthcare is simply having Husky, because there's this implicit bias that if you have this type of insurance, you must be this type of person.
I've seen COVID highlight and exacerbate the social determinants of health in underserved communities and communities of color. Here, people, a lot of different towns, even our state legislature, declaring racism as a public health crisis. So people are having these conversations, but many of us know that we've been having these conversations for far too long.
How does the implicit bias in the healthcare industry, otherwise known as the unconscious preconceived notions that people have surrounding other groups of people, how does these implicit biases have explicit effects on the healthcare outcomes, specifically for Black people?
When I was in the greater New York area, there were patients who had breast cancer, had surgery, and needed the radiation. And there were women of color who were not going on to their radiation. There was a preconceived notion that they would be non-compliant with the radiation because they had difficulty getting in for their routine, just a surgical appointment or the chemotherapy, and radiation is every single day, usually on average 4 to 6 weeks. And I think that there were some clinicians who thought that they were actually doing the patient a favor by not adding that additional every day for 6 weeks. But we know that abbreviation of the treatment has long-term implication in terms of overall survival.
The maternal mortality rate in the United States has increased while around the world it's been decreasing. The rate is about 3 times higher depending on what region you are in. And you used to think that a lot of that was due to socioeconomic status. However, when you take out that factor, the Black maternal mortality rate is still higher. The reason why that happens is implicit bias, are the assumptions, are that Black women generally feel not listened to, especially when it comes to pain. And I think some of that is representation. Some of it is that the doctors don't see themselves in the patients, and some of the patients don't see themselves in the doctors, and so the communication is not great.
The majority of our patients are Hispanic and Black. And so our patient complaints are normally, the provider just assumed I had drug-seeking behaviors because I said I had pain, and they won't prescribe anything. or, you know, the provider rushed me or refused to get a translator. There are just these assumptions that are made about patients based on what they look like, whether it's their skin color, their gender, the clothes that they wear. If you're a provider or, you know, even an administrator who grew up with certain stereotypes or opinions of a particular racial or ethnic group, that carries over into your everyday work, whether you know it or not, whether it's intentional or unintentional. A quick example is a colleague of mine made this comment that he just assumed that because I was Black and another colleague were Black, that we understood each other or we knew each other or had like common opinions. And I said, why? Because we're Black? And he said, yes. And that was just a belief that he grew up having. And so because he grew up with that belief, it kind of dictated how he interacted with other Black people in the office.
What are the ways in which people take into consideration those preconceived notions that they have against other groups of people?
First thing is to acknowledge that everybody has implicit bias, which, and the whole point of it being implicit is that you don't really realize that you have it, you know, which is why I think increasing diversity in medicine and representation is so important.
And this one again is open to everyone, but why should racism be declared a public health crisis? And how can everybody in this call help with that fight and that struggle?
You cannot cure what you cannot diagnose. And so we cannot make pleas or make demands about having, you know, certain funds and resources and services assigned to the Black and Brown community if we cannot even acknowledge that racism even exists. And so the declaration is a start, but there needs to be some real power behind that. We need some real conversations and committees put together to acknowledge the redlining, to acknowledge, you know, the housing insecurity, food insecurity. We have to acknowledge that people Black and Brown people do not have access to quality health care. We have to acknowledge that, you know, that kids in New Britain or Hartford are not getting the same funding as kids in Farmington or Fairfield. In order to be able to do that, we have to make this declaration.
I want to thank you all once again for joining us, and I want to give a sincere thank you to all of our panelists. You guys' insights and knowledge is genuinely astonishing, and I know that I've gained so much from this conversation today, and I know everyone listening has as well. So thank you, thank you, thank you. And I encourage everyone listening to take some action steps, whether they're ones that you've heard here today or ones you were thinking about taking prior to this. I strongly encourage you to find a way in which you can make active change in whichever communities you are in.